Assalamu alaikum warahmatullahi wabarakatuh. Part of motility disorders of GI disease. A 45-year-old man has a 2-year history of chest pain and dysphagia that was initially induced only by solid foods but has progressed over the past year to include both solid and liquid. يعني عنده مشاكل بالابتلاع بالسائل والصلب. He also described intermittent chest pain, retrosternal burning, with occasional regurgitation of undigested food and 4.5 kilogram weight loss uh, over the past 2 years. Physical examination is normal. Upper endoscopy shows a small amount of retained food in the distal esophagus, but it's otherwise normal. The endoscopy passes easily through the esophagogastric junction and bypass specimens are taken. An esophageal motility study demonstrates a hypertensive lower esophageal sphincter that doesn't relax fully with weight swallows. That means this diagnosis of achalasia. This is the picture of achalasia on with barium swallowing with X-ray. Achalasia of the esophagus. Now, after we taking the case, now we will give the information. Achalasia of the esophagus. Pathophysiology achalasia is characterized by a hypertonic lower esophageal sphincter which fails to relax in response to the swallowing wave. That means there is hypertonicity in the muscle. That means similar to muscle spasm of the lower junction between the esophagus and the stomach. Failure of propagated esophageal contraction leading to progressive dilatation of the gullet. That means where there is a failing in the relaxation in the the gastroesophageal junction, that means there is losing of propagation أو تعاظم الcontraction الموجود بالesophagus. That means will lead to the dilation of the gullet or dilation of the esophagus. The cause is unknown, maybe due to degeneration of ganglion cell within the sphincter and the body of the esophagus occur, or the dorsal vagal nuclei within the brain stem can be demonstrated in later stage. That means maybe they suppose that there is loose from the innervation of it. The clinical feature, how it's present to us, how the patient come to us. It usually develop in middle life. That means in middle aged, but can occur at any age. Dysphagia develops slowly. Dysphagia is important, develops slowly and essentially intermittent. It is worse for solids and eased by drinking liquid and by standing and moving around after eating. Heartburn doesn't occur because the closed esophageal sphincter is important. The heartburn not occur because of the closed gastroesophageal junction or sphincter. This is another picture showing the lower contraction of the gastroesophageal junction. The investigation, important investigation to do it. Chest X-ray may be abnormal in late disease. That's important, late disease, not in the beginning. With widening of the mediastinum, how we can see it's abnormal by widening of the mediastinum from the gross esophageal dilatation and features of aspiration pneumonia. So we will see there is a widening of the mediastinum in the chest X-ray. A barium swallow, it's important, another tool. Show a tapered narrowing of the lower esophagus, important words. Tapered narrowing of the lower esophagus. Endoscopy, the third one must be always carried out because of the carcinoma of the cardia and mimic the penetrating the presentations and the radiological and manometric feature of the achalasia. That means we need chest X-ray or barium or endoscope. This is the three tools, important tools in the investigation of the achalasia. The management, how we can manage a patient with achalasia. Endoscopic forceful pneumatic dilatation. That means we introduce a balloon and expel this balloon or fill this balloon with air, and that will lead to dilatations. A forceful dilatation, 30 to 35 millimeter diameter for fluoroscopy. Positioned balloon disrupted the esophageal sphincter. Some patients require more than one dilatation, but thus require frequent dilatation are best treated surgically. So, if the patient needs a multiple time to get a forceful dilatation, the best tool to treat him is the surgery. Another case, a 67-year-old woman has an 8 to 10-month history of intermittent dysphagia for both solid foods and liquids. The dysphagia initially developed over the course of 10 to 14 days. She reports no abdominal symptoms but has lost 13.5 kilogram during this time. An upper gastrointestinal barium radiography shows a smooth narrowing in distal esophagus. It's similar to the achalasia, if you remember the barium swallowing. Esophageal motility study is consist with a case, so the diagnosis is a case. It's an important case. Another one, a 55-year-old man has several years history of epigastric pain and daily heart pain without dysphagia or weight loss. It's important without dysphagia because we say the sphincter is closed. He has tried over-the-counter antacid. He used antacid to treat himself, and more recently intermittent over-the-counter proton pump inhibitor, but still has breakthrough the symptoms. Physical examination is normal. This is another case of achalasia. Now we will jump to another subject, diffuse esophageal spasm. Present in late middle age with episodic chest pain which may mimic angina. It's important. Esophageal spasm, it's similar to angina, but sometimes combined by transient dysphagia. So, how we can differ or differentiate from the angina from esophageal spasm? When it's combined by transient dysphagia, that means it's a esophageal spasm. Some cases occur in response to gastroesophageal reflex. The cause of it is the gastroesophageal reflex. Treatment is based upon what? Protein pump inhibitor. The usually used treatment for the gastroesophageal reflex, or H2 antagonist, right? Or lifestyle modification to stop the gastroesophageal reflex. Or sublingual nitrate or nifedipine, it's important drug to relieve the symptoms of spasm that we use in angina, also used in relaxing the spasm of the esophagus. May relieve attack of pain. During therapy is often disappointing, as are the alternatives, pneumatic dilatation and surgical myotomy. Maybe the drugs and the alternative to it may be disappointing in treatment, and that will lead bad prognosis. This is another picture of the esophageal spasm. We can see the spasm along the esophagus. And systemic sclerosis. Now, this another subject. The systemic sclerosis in the muscle of the esophagus is replaced by fibrous tissue. That means there is a replacement by fibrous tissue, which cause failure of peristaltic. When there is failing or failure in the peristaltic movement, that will lead to what? To stacking of the food inside the esophagus. That will lead to heartburn and dysphagia. Esophagitis is often severe. Why severe? Because there's a lot of time of exposure of the content inside the esophagus. And benign fibrosis structure occur, and there formation of the structure, but benign, not carcinogenic. These patients require long-term therapy with a protein pump inhibitor to reduce the acidity and the symptoms. The dermatomyositis or the rheumatoid arthritis, myasthenia gravis may cause dysphagia. This is some examples that may cause dysphagia in addition to other subjects that we studied. This is table to demonstrate the cause of esophageal structure. We have gastroesophageal reflux disease. We said that wave and rings may cause structuring, carcinoma of the esophagus itself or cardia, or extrinsic compression due another carcinoma from bronchus, corrosive ingestion, that means ingestion of corrosive substance to esophagus, post-operative scarring following esophageal resection, that means after surgery and scar formation, post-radiotherapy, and we know that radiotherapy may cause structure formation and benign structure, following long-term nasogastric intubation, that means there is a response or spasm or immune response to the intubation and will lead to formation of the strictures. Benign esophageal strictures is usually a consequence of gastroesophageal reflux disease and occur most often in elderly patients who have poor esophageal clearance rings due to submucosal fibrosis. There is a submucosal fibrosis in this area. Occur at the esophagogastric junction. Chatatsky rings, I don't know how to spell it, and cause intermittent dysphagia, often starting in middle age. That means Chatatsky rings, it occur in the middle age and it's similar to benign esophageal structure. And the cause, we know gastroesophageal reflux is the cause of this benign structures. A post-cricoid wave is a rare complication of iron deficiency anemia. There is another complication, another subject. When there's someone have iron deficiency anemia, will lead to the post-cricoid wave. Or someone called Patterson-Carley or Palmer-Venosum syndrome, and may complicated by the development of squamous carcinoma, and that maybe will lead to squamous carcinoma. Benign structure are treated by endoscopic dilatation. This is the treatment, how we can treat it. Dilatation but with endoscopy, in which wire-guided budgies or balloons are used to disrupt the fibrous tissue or the structure. That means we will introduce wire-guided budgies inside the esophagus and widening of the balloon to distract or disrupt the structure of the fibrous tissue. For now, we will stop at disease of the stomach and do not thank you everyone.